And you are now live.
Thank you. This is Senate Appropriations, and we're continuing our work on the budget adjustment. And today we're taking testimony from the Department of Vermont Health Access regarding the requested budget adjustment. Obviously, Medicaid is always a big piece generally of any adjustment. So we have Commissioner with us, and Steve, you want to give us your official title?
The Chief Financial Officer of DIVA, Senator.
Okay. All right. CFO. All right. So I'm going to let you take it. Do you need screen sharing? Is that what your plan is, Andrea? Are you Andrea or Andrea?
Whatever your preference, Senator Kitchell. I'm not very particular about it. But I'm pleased to join you today, and I thank you for having us. For the record, my name is Andrea DeLabriere. I'm the Commissioner of the Department of Vermont Health Access. And what I'd like to do, if you're comfortable with this approach, is introduce the team that's joining me today. We have a number of subject matter experts here to answer questions at the end. And then I could provide a brief overview of our SFY 22 budget adjustment, and then hand off to Steve for the walkthrough of the narrative as well as the ups downs. Does that sound like a good plan?
It's fine. Yes, we'll see. Oh my goodness. You have quite a few staff members with you.
We do. This is my 4th week in this role, so I need additional supports, and I'm appreciative of their opportunity to have them here with me. But I'll be quick and be brief with the intros, if that's okay.
I think it's very fine, because that way any of us will know who on your staff to call, and if they would at least turn on their videos so we could sort of meet them, even if it's remotely, that would be great.
Perfect. That sounds wonderful. So I'll start with the central office, Senator. The CFO, Richard Donahue, is with us, as well as the financial director, Tracy O'Connell. And then from the DIVA team, we have former acting commissioner and current deputy commissioner, Addie Strumolo. We have our CFO, our DIVA CFO, Stephen Wislowski. We have our deputy commissioner, Sandy Hoffman. And then we have Dr. Alicia Cooper, who is our director of managed care operations, and Dr. Nissa James, who is our healthcare director. And I hope I got your title fully right, Nissa. So that's the team with us today. And we are here to present the SFY 22 DIVA budget adjustment, which represents just under $107 million in new appropriations, with $48 million in state funds. By far, the primary driver is the increase in Medicaid caseload.
Whoops, can't hear you. Is somebody not muted? Because we were picking up a conversation.
I think they are now. Senator.
Okay.
So by far, the primary driver is the increase in Medicaid caseload. And as you may already know, federal law prohibits us from disenrolling Medicaid members during a declared public health emergency.
Yeah, and disenrollment, I knew that we weren't doing reviews, but I had no idea that in fact you were not allowed. If somebody called and said, I'm moving, or I've got a new job, take me off. We've had people commenting that they've tried to say, close me out, and you can't even do it. They raised the question, if somebody dies, are we still paying a capitated payment for people who have died?
That is a great question, and I will have to defer to Deputy Commissioner Strumolo to answer that.
Sure. Hi, this is Addie Strumolo, Deputy Commissioner at DIVA. There are exceptions to the continuous enrollment provision under the Families First Act, including voluntary requests and death and lack of residency. So I think we should follow up on the cases you're hearing about where people are being told they can't come off if they want to. There is definitely exception for voluntary requests.
Okay, thank you very much for confirming that, because it seemed rather extreme. One would assume if you're dead, you're not getting healthcare services. On the other hand, under a capitated arrangement, we could, if if they're still active on file. So you're able to do that. Thank you.
Okay, great. So we clearly fully support this approach, and we want Vermonters to have access to healthcare, but it has resulted in an additional 30,000 Medicaid members since March of 2020. So this increase brings the total number of enrolled Medicaid members to 206,000, which is confirmed as of the report dated the end of December. I should also note that maintaining continuous healthcare coverage is a requirement for us to be able to receive the additional 6.2% federal medical assistance percentage, which is also known as the FMAP, which I'm sure you're very familiar with.
I've heard of it.
I'll bet. So at this point, the timeline for declaring the end of the public health emergency is really unknown. But when the federal government does declare the end, we can then begin, the DIVA team can then begin the work to unwind, which also means redetermine eligibility. So that's my brief overview. Unless you have specific questions for me, I'd like to turn it over to Steve to walk through the narrative and the ups, downs.
Okay. Any questions of the commissioner? Otherwise, we'll get right into the money.
Yes, I have one question
Senator
about,
Sears.
did I hear you correctly? There are 200,000 people on Medicaid in Vermont?
206,000.
206,000, and there's approximately 650,000 people in Vermont. So that's nearly a third of the population.
Almost a third, correct.
Okay, and what pre-pandemic were our numbers?
Again, that was before my time. I would have to defer to Deputy Commissioner Addie Stremolo.
Or Stephanie might know that too, because those are consensus numbers. But obviously, how long since we've been actually able to do eligibility reviews? That also helps determine how much how long we've gone without really purging our caseload for ineligibles.
The point of my question is really about if it's that a third of Vermonters, and I know the impact on the rest of the healthcare system, because Medicaid pays less than others, and then we've also got the Medicare population, which pays less than others. So it's putting it, I would assume that it's putting a huge pressure on the rest of the healthcare system. Either the private pay, that doesn't have any insurance, few people hopefully, or those with, healthcare plans.
If you have a plan, Medicaid, I think the rule is not changed, is the payer of last resort. So anyone who might have gone back to work and has got insurance through their job,
I meant people who were never on Medicaid. The provider, the hospital, charges to self-pay more than they do anyone. Then your Blue Cross Blue Shield, MVP, and other insurers pick up the rest. So I'm just trying to understand the impact of having a third of Vermonters on Medicaid.
That's a great question, Senator. I think that we are looking deeper into the utilization aspect of this. And what we should have better numbers, but at this point in time, it seems like utilization has been on the decline. So I would confirm that with Addie, though. She's the expert here.
Okay.
Well,
thank you. I didn't mean to stall the whole presentation, but it's just a shocking number.
Yeah, it is a very large number, no question about it. And we'll have a breakdown because a lot of them are children. We've always carried a lot of children on the program through Dr. Dinosaur.
Yep.
Senator Kitchell, if you'd like,
Yeah.
Just to clarify, we stopped processing eligibility redeterminations in March of 2020. So it's been, a solid year and a half, almost 2 years now. And our total enrollment at that time was 176,500. So as Andrea said, we have increased by about 30,000.
Mm-hmm.
So in the scheme of things, this kind of 1/3 benchmark is not too different than what we have now, but we obviously have grown because of the provisions.
Thank you. Any other questions? Dick, are you all set now or you for now? Senator Sears?
I'm trying to eat my lunch. So
Oh, sorry. Okay.
that's
All
okay.
right.
No, I'm all set. Thank you very much.
All right. So I guess now we'll move on. Do you prefer Stephen or Steve? We just found out that Steve Klein preferred to be Stephen, and we only learned that 20 years later. So are you Stephen or?
How about I'll stay for the record, Steve Wisloski, Diva CFO.
Oh,
And either is fine, but it's really my
Okay.
mom, and when I'm in trouble that I'm Steven. So,
Uh-huh.
but
Mhm.
so just by way of protocol, I know there's some hesitancy for presenters to share their screen. I wanted to just confirm. I saw on the website that you have our narrative and our ups downs, sort of the Word document, the Excel document. Does everybody have that first? Let me, before I get into it, do you have I think the Word document is the one.
Yes, we do have the Word document for any of the language
Yeah.
that was sent. Do you want to do the language or the most attractive member of the Star family has just entered the screen here. Do you want to do the language or the money, or do you want to do crosswalk it?
How about we do the language, and then if anybody has any questions that they'd like to deep dive on the crosswalk, then we'll jump over to how does that sound?
Okay. All right. Committee, do you have the language section copied off?
And if not, I can share the screen if you prefer. Just holler if you'd like me to share screen.
All right, committee, you want to scare us rather than trying to find it? Do you want to just put it
I'd
up on the
rather-
screen?
Please put it on the screen.
Okay, we'll put it on the screen. I do have my copy here, but sometimes it's easier just to put it on the screen.
Okay, great.
Can you all see that?
Yeah.
Okay, thank you, Chrissy. So, okay, and just a couple of intro comments. So, DEVA, Department of Vermont Health Access, our SFY, our state fiscal year 2022 budget as passed in the last session was just under $1 billion, $993 million. And that lives in 4 paragraphs in the appropriations bill, section B 306, 307, 309, and 310. 308 is missing because at the end of 2020, that was long-term care. That went over to the Department of Aging and Independent Living, Dale. So that's why we don't have the 308 anymore. And when you look at those 4 paragraphs, they're really, the B306 is what we call our administrative section. And then 307, 309, and 310 are what we call program. And program is the majority of the money. If it's, $1 billion, about 830 million of it is in delivering services. And then the other 160 or so is in what we call administration. That's our 306 paragraph. And so that is all the vendor contracts, IT projects, people, work that we're doing with the Agency of Digital Services Operations and so forth. So sort of the delivery of services activity. And so when we go through what we call our ups, downs, just the changes to dollar amounts in our 22 budget as passed, we have 16 that we're going to walk through today that are in this narrative, 6-page narrative. And 5 of them are in that admin budget in 306. And then the other 11 of them are in 307, 309, and 310. And just before I get in, you might say, well, how come you have 3 appropriation paragraphs in your program and your services and only 1 in admin? The 3 in program are divided up simply because of the types of funding that's used and the types of services that are provided. So B307, when you look at the four of them, is really the big one. That's over $750 million, and that is our global commitment, right? That is our basic Medicaid funding, which, in a typical year breaks down to about 56% federal, 44% state. But because of that enhanced federal Medicaid assistance percentage that Commissioner De La Brea referred to, we're getting an extra 6.2 percentage points of federal government assistance. So instead of 56, it's more like 62.2. And so that's, but as a condition of receiving that money, we have to basically keep everybody on the Medicaid rolls. So that's why we're at 206,000 people and not 176,000 people. So that's where you're going to see the biggest increase in our budget, for this budget adjustment. Then the other two paragraphs, 309 is what we call state only. And as it sounds, that typically is general fund, except if you look at the summary, you'll say, well, gee, it's 3 times as much gross as it is state funds. Why is that? Well, it also includes a subset of our global commitment funds, which are dedicated to what we call investments. So it's kind of a special category, and it's a limited, category where we only have so much authority from the federal government to spend, and that falls in our state-only appropriation. And then the last one, B310, is what we call non-waiver. So that's items for which the federal government participates, and there's a larger federal than state share. However, it's not under global commitment. And a lot
That would
of
be like S-chip. It's talked.
Correct. Exactly. That the biggest one there is CHIP. Exactly. S-chip. So that's where we're talking about admin versus programs in 3 buckets, admins in a single bucket. So that's the overview. Any just general questions about how DIVA's funding is organized before I launch into the ups and downs, the actual
Well, I'll see. This committee is fairly experienced. We haven't changed much, and so we've got a lot of institutional knowledge here. So I don't think so. I think we understand and the different program components and the fact that there's different funding constraints or parameters for each. So, and global commitment, we certainly understand. So I don't see any hands up. Maybe I'm missing. No, so why don't we keep going, and we'll start with admin at B306. Keep going.
Okay, great. So item number 1. So the overall in admin, there's really not much of a change on a gross basis, but there is a significant increase, about 2.6 million of state funds. And that's driven largely by just one of these items, but I'll walk through. So the first item is just Vermont Health Information Exchange. And this is kind of a routine, just change in the annual contractual spend here. In this case, it's a slight down, 845,000 gross and 255,000 net. That's just a slight decrease in the contractual deliverables, and then also the discontinuation of a grant that the Vermont Information Technology Leaders Vitals is actually going to take in-house.
Okay.
All right. Item number.
That raises, in the past, there's been some, there was sort of like concern that although DIVA was moving the money through, this a few years ago, and before you came, Steve, that there wasn't sufficient oversight and monitoring of what was happening with Vital and just sort of passing through the money. And then that got caught up and was corrected. So I just raised the question in terms of the oversight. Is that something you're responsible for, or who within the department would be the lead person to be monitoring the work there for the funding? Because you have a contract.
If any of the folks within AHS or DIVA want to take that question before I attempt my understanding of it, just pause for a second. So,
And people have changed. So, and I guess maybe Senator Westman, you remember this, and there was concern that we had a contract, but no one was really monitoring. It was more of a pass through, and there was really concern about, what was, the deliverables. And then, so there was a commitment that DIVA had to really have greater oversight and scrutiny of that work. So I'm just wondering, who is that happening, and who is the lead person doing that?
I'm happy to take that one, Steve, if it helps.
thank you, Commissioner.
Okay. So Senator Kitchell, there are some complexities here but essentially programmatically, the Health Information Exchange, VITAL, is managed through the central office.
Oh, okay. Okay.
Funding still streams through DIVA at this point in time.
Who in the central office then would have been assigned that responsibility?
Sure. So Ina Backus.
Oh, it's Ina?
Yep.
I know. All right. I just,
Sure. There's a lot of moving parts.
oftentimes we find out everybody's involved, but it's not clear who's accountable. And that's what I'm asking because of, what happened a few years ago. So
Completely
thank you.
Understand. And I worked for VITAL, so I further understand.
Yeah. All right. Yeah. All right. We'll keep going. Thank you.
Okay, thank you. All righty. Chrissy, if you want to go to item number 2. So for this one, folks will remember last legislative session, Act 48 expanded Dr. Dinosaur-like coverage to individuals regardless of immigration status. And the legislature identified $1.4 million of general fund for the purpose of starting this initiative. That actually was appropriated in DIVA's section or paragraph B309 state only. However, in order to build the capacity in our what we call our Medicaid Management Information System, or MMIS, the software that handles the claims for Medicaid, we needed to actually move some of this funding up into our administrative budget for contractual increases for personnel costs of seeing those contractual increases implemented, because you have to build the functionality, but then you have to make sure that the data on those individuals doesn't get pulled in and reported to the federal government, because the folks aren't actually eligible for Medicaid.
Mm-hmm.
So we're providing the ability to process claims for them as if they were on Medicaid, but then we can't have them getting reported up as Medicaid members. So this is to move $200,000 for that activity from kind of our program budget into our administrative budget.
All right. And that's really for the cost of the MMIS, setting up a module so that we're making sure that it's only, those services are only being charged to general fund.
Yeah, that would be part of it, and then the other part of it is so that we can basically handle them as if they were Medicaid members, provide the services if they were Medicaid members, but not report them up to the federal government. We've got to sort of ring fence. So it's called suppressing the data.
All right.
Okay. The next item, number 3, is
let me ask, what is the experience to date in terms of the take up relative to the estimated enrollment?
I think Deputy Commissioner Strumolo, do you want to do you have a little bit more information on the experience?
I think we should defer. If Nissa James is on, I think that she'd be best positioned to answer the questions about Act 48.
Okay, thank you, Dr. James. Sorry about that. And I thought I saw her dialing in.
If you don't, you can just take a note, and if we ask questions, it's all right. just send us a follow-up and with the information. So we'll just keep going. I'm sorry, it just raised the question. Sometimes
No,
take-up is quite a bit less than we anticipate, and sometimes it's hotter than we anticipate.
Right. And I'm sorry, yes, I think we're having some technical difficulty hearing from Dr. James. Actually, I should elaborate a bit. So the changes to the information system so that we can actually collect the data and do the analysis as to, okay, what really is the uptake and how much is this really, do we anticipate that this will cost in a given year? That will roll out July 1st of this coming year. However, the dollars are actually available to pay for these services in the current year. And so we're handling that through grants with several providers. And so to my knowledge, I don't know that we've actually received the first invoices for those yet, but that ability is there. So we're able to sort of process paper requests for funding, but the ability to, actually kind of granularly analyze the data isn't going to be available to this coming July 1st. But we should have some information this year. I just don't know that we have any available yet.
All right, that's fine. We'll just keep going then.
Okay. All right. So the third item, patient access to healthcare or interoperability. So this is just some software changes to follow to enact some directives from the Centers for Medicare and Medicaid Services, CMS, that require us to make healthcare information available to our members on their personal devices. So, for example, on their personal computer or their iPhone, and it's creating these application program interfaces, so or APIs they call them, and this was in the works during our 22 budget development, but we simply didn't have the proposals and the concrete cost information in place in time to incorporate it in our request. And so, the work is going to start in the second half of this year. And so this is for kind of a partial year's worth of anticipated costs related to the CMS requirement.
And the match on that's only 50%?
Yes, it looks like it is, and there's got to be a good reason for that. Why that's not enhanced funding, Senator. I don't have that at my fingertips, but that's a good point.
Okay.
I am wondering. I mean, typically when we see that, it's related to the change has to be certified in order to receive either 75% or 90% funding. And so I'm wondering if this it's either not eligible for enhanced funding or it needs to be certified in order to receive it. I'll take a note as to find that out. But that's a very good observation that it's only 50% funded. The next one is, you'll see that there's no change in the gross dollars, zero, but it's an increase in the state share. And that is due to a change, it's the same amount of activity, but it's a change to the cost allocation, and an unfavorable one for two reasons. So the activities in this item previously were funded by what was called the High-Tech Act, and that passed way back in 2009 and provided 90% federal share. But that finally ended in September of this year. And so in order to continue to receive federal participation, we had to migrate this activity to what are called our advanced planning documents. We have implementation and operation advanced planning documents. And, we work with CMS on those and receive federal participation that's ranges from 50% to 75% to 90%, depending on the activity. But the first change is it's not all 90% anymore. It's going to be a portfolio of federal participation, depending upon whether it's development work, which would get 90%, or maintenance and operations work, they call it M&O, which would get you 75%, or activities that don't qualify for enhanced funding, which only get 50%. But it's not all 90%. And then the other change is that because we have to use, and these advanced planning documents, these plans with CMS require what's called cost allocation plans. CMS wants to make sure that whatever they're paying for is being applied to Medicaid members. And the Vermont Health Information Exchange has data, processes data on more than just Medicaid members. There are also people, for example, who are on the qualified health plans, the exchange. And so in the absence of being able to demonstrate that, say 2/3 of that data is actually Medicaid member data, which is what we think it is, we have to revert to what they call as a geographic statistic. So when we talked a little earlier about 206,000 people on Medicaid and 625 or 650,000 Vermonters, that unfortunately is that roughly 30%, I think 32% here, is the share that Medicaid that CMS will cover. So that's basically the two unfavorable changes to the cost allocation. One is you have kind of a mix of federal share between 50 and 90%. And then the other is that the federal government's only going to cover the share that's allocable to Medicaid members. So we hope to get the statistic to improve and the state up, if you will, the state funding up to come down when we improve the cost allocation statistic, but we're working with Vital to get that information, transaction data, to say that, really the federal government should be covering more like 2/3, not 1/3 of the cost. Sorry, that was a very long-winded explanation. But basically,
I understand. So we built a budget assuming a certain level of federal receipts that for these reasons is not going to be possible. So we're having to adjust the state share. And hopefully once we get, I guess you've got the APDs in. So hopefully we'll be able to get back to a good cost allocation and also get the 75% upon certification. So I'm going to just keep going because I'm just looking at, our schedule here, and I need to get through at least the overview of the budget adjustment in the allotted time. And we started a little bit late, so we'll go a little bit later, but we'll just keep going unless I have questions, and I don't happen to see any right now.
Okay. So the next item, just a technical change. This is agency neutral. This is just a transfer of some of the agencies carry forward to DIVA for our state share of to pull down the federal matching funds in the Health Information Technology Fund.
Okay, now we're getting to the big one here, the caseload.
There you go. Yeah. So that was admin. So those 5 items constituted our admin budget, or the ups downs for our admin budget. So now getting into program, the remaining have 11 items. And yes, this is the big enchilada, the number 6. This is changes to caseload. So because we have 206,000 people instead of 176,000, this is the up. And we received the question in another committee, could we have foreseen this? And the budget development process is so far in advance. So what the process that actually went into developing our 22 budget as passed was about 15 or 16 months ago. And the underlying assumption was that the public health emergency would certainly be over by the following March. And, here we are, March is just around the corner. We're still under the emergency. And so that is the reason for this, this increase of 67 million gross and 29 million state is relative to where we thought we were going to be about 15 months ago.
Well, I wish we would have that ability to predict, but I don't think we did. And it's a consensus forecast with joint fiscal staff. So and then the federal requirements and the extension of the enhanced match, but with it, the no redetermination would have been very hard to predict what Congress would do. So I'm not surprised what your response was to the question.
Okay. And if we, Chrissy, if you just want to go to the bottom of the page, I think it just to say that the 67 million is almost entirely in our global commitment funds. There's
Mhm.
actually a little bit of a reduction in the state only, just the utilization reductions in our V-Farm program. And then the non-waiver portion, Senator, as you said earlier, it's CHIP. You know, there's a little bit of an allocable piece in the Children's Health Insurance Program, but by and large, we're talking global commitment dollars when we're talking about the increase. Okay. Any questions on that one?
No, and I think out of that population, is it, Stephanie can answer this as well. It's the new adults that we're seeing the higher number,
All three of
particularly.
the adult categories, general adults, new adults with kids, and new adults without kids.
Okay.
I think mostly new adults without kids is the main.
Yeah. Okay.
Okay, the next one, item number 7. So this is a transfer from the Department of, again, an agency net neutral item. It's a transfer from the Department of Mental Health to DEVA related to our alternative payment model contract with the Brattleboro Retreat. So it's 13 million gross, of which the state component of that is about 5.7 million. And then you can see this is one of those special items where it's global commitment dollars, but about 9.5 million of it is what we call investment dollars that are capped as to the total amount. The reason that they're investment is that it's either forensic folks, which means that they're involved with the agency or the Department of Corrections, or it stays at the retreat that are longer than 60 days. So the expenses related to that are allocable to our state-only category as opposed to our global commitment category. Item number 8 is another transfer from DMH, a much smaller one, and this is for the Northeast Family Institute of Vermont, and it's for a hospital diversion program for adolescents. Item number 9, this is related to annualized adjustments to our Medicaid rates. It is 4.7 million gross, about 2 million net. The breakout is between our global commitment appropriation, and again, that small portion in non-waiver is allocable to the Children's Health Insurance Program. If there are any questions related to that.
See any? We'll keep going.
Okay. Item number.
No. Maybe we're getting to it. We're all getting emails, support the primary care increase. And I understand that is aligning the Medicaid with the Medicare. And is that yet to come up in these documents, or is that something separate?
So I am going to ask, before I misspeak, I'm going to see if Dr. Alicia Cooper is available to weigh in on that one.
Okay, the commissioner gave me the answer, why we were getting the email saying support DEVA's request that will increase primary care reimbursement. I'm sure I'm not the only committee member that got those emails.
This is Alicia Cooper. Good afternoon. For the record, the Director of Managed Care Operations for the Department of Vermont Health Access. To answer your question, the primary care rate changes are a part of this overall line that Steve just walked through. They represent approximately 3/4 of the overall amount that's there. But this line also includes updates to a number of other Medicaid reimbursement systems, including, for example, our hospital outpatient reimbursement system, our home health and hospice reimbursement, and our federally qualified health center reimbursement.
And which appropriation, are we talking about out of that gross of 4.6? I mean, you're going to do all that? Or which appropriation are you referencing?
Yes, we are referencing number 9 in the narrative there. The 4.6 represents the portion for the component of the federal fiscal year 22,
right.
and then we'll have
I just wanted to be clear, because the way the screen was, I couldn't see the narrative above the numbers. All right, so that's what is the genesis of all the emails that are coming out.
Yes.
All right, thank you.
Okay. Item number 10, this is for the Accountable Care Organization reconciliation or settlement payment for performance year 2020. So basically calendar year 2020. And that is just under 15.4 million gross or 6.7 state. And, this was a payment to the ACO this year. But in past years, specifically in 2019, we actually had a $6.7 million payment from the ACO. So it just, went the other direction this year.
This has been a topic of some public criticism. And the way some people have described it is, I know with the mental health, paying the underpayment reform, getting out of fee-for-service really gave financial stability, and which would have been a real problem. So when the payment goes to the ACO, to what extent would that money have gone to help stabilize, the hospital revenues, et cetera, that would have still gone out to the provider network as opposed to being retained? The question that comes to mind is, it's one thing not to penalize because of COVID, but is in fact OneCare under this getting rewarded because of COVID in the form of savings that are imputed to be a result of the management of care, as opposed to services that weren't provided because of COVID. And does your methodology account for that? Or at some point, do you true it up and say there's too much retention of profits and make adjustments? I don't know who wants to take that one.
So I'm happy to address that question. Thank you for articulating those questions that you've heard. I think that it's certainly the case that COVID-19 caused system-wide decreased utilization of healthcare services during the 2020 performance year for our ACO contract. And it's likely that that system shutdown that we experienced contributed to the lower than expected total cost of care during the 2020 performance year. I think it's also important to note that the reconciliation payment that we are making to OneCare to the amount that was just described in narrative item 10 is a contractual obligation from DVA's agreement with OneCare Vermont, and it is limited by a risk corridor that we have in our agreement. So while it's certainly true that OneCare is receiving a payment because their actual expenditure for the healthcare services for the attributed population was less than expected, it was actually lower than the bottom of the risk corridor, which means that we are limiting how much money they can receive through our contractual arrangement. So I think that goes to your question about whether there's a limit on how much they can sort of profit from this type of arrangement in your phrasing. I think it's also important to note that the dollars that would be going to OneCare via this reconciliation are not intended to solely be retained by OneCare. They have contractual obligations to their participating providers for how any savings through their payer arrangements are then distributed to the provider network. And so this reconciliation payment to OneCare will allow for additional resources to be directed to the healthcare system as COVID-19 pressures continue at this point in time.
All right, I think that's so important, the last what you're saying, is because it appears as though it's being interpreted as it's enriching OneCare But what you're saying is OneCare then has obligations to its network of providers, and that they would use those contracts would be honored, which would then give money out to the provider community. It's not all being retained to enrich OneCare.
That's correct.
All right.
Madam Chair?
Committee, I just think that's so important to understand, because we also have been putting money out to stabilize healthcare providers. And so it's sort of like, well, how does this all fit together? And I'm, to what extent, what you're saying is the providers that are under this risk arrangement with ACO are going to get the predictability of their revenues in the same way as the designated agencies were able to get that predictability for their revenues.
Correct.
Is that, so what we're going to see is then some of that 15 million would then go out to their provider network.
Correct.
So,
Okay.
Madam Chair,
Yes. Yes, Senator Westman, please. I
So-
just think that it's really important to get this understood, because there's been so much press and so forth that I just think that this explanation is very helpful, because it appears that somehow they're getting something that they shouldn't get, or they're getting rewarded because of COVID. And the next step that the money would go to providers. Just a sec. I've got to take a phone call from family. So Alice, you want to continue, please?
Okay, yes, continue. Go ahead, please.
Okay, I guess we'll move ahead to item number
so
11.
I would like to ask a
Sorry.
question before you
sorry.
move on,
Please.
or at least make a comment.
Please do.
I understand what you said about the money going out directly to providers. But from a public image standpoint, when OneCare is out doing ads on VPR and a number of the different media outlets, who's looking at their budget in the overall to make sure that the overall organization, that this is the right number in the right place?
I think for questions about OneCare's overall budget, we would defer to the Green Mountain Care Board and their review process.
So there's no relationship between this number and their overall financial situation.
Well, this would be part of it.
Well, I understand this is part of it, but the argument and the point they're making is this money's going directly through to providers for the most part. And I have to say that when OneCare is out doing ads, that doesn't look like direct service to me when you're over budget.
I guess that's a question we'd have to direct to the Green Mountain Care Board, and the extent to which, because they're the regulator of the overall managed care organization, which is getting Medicaid is only one funding stream. Are there any, well, once they get the money, I don't know, are there constraints that would preclude the, I remember when Vital did the ads, remember, before Super Bowl, and what a
Absolutely.
so it's raising that question.
Yes.
All right. I think we need to direct that to the Green Mountain Care Board. And who's the market
Right.
that it's being addressed to?
And in the overall, how does this all fit together?
Yeah. All right.
Do I
All right, so we'll put that down to see if we can better understand any constraints. And also, with these public dollars, are there any limitations on within the contract? But I don't know. Once you get the money, there's certain constraints on admin cost at whatever. So we'll put that on to get more information. I'm just looking a bit at the clock. It's a little after 2, so I'm going to suggest we keep going because we have after this, we have the Vermont Vets Home, and then we have Dale. So we'll make a list of questions and see if we can get answers. Stephanie, are you kind of keeping notes?
I am a bit, I'm also multitasking, so.
Okay, all right. Well, I'll try to keep notes too. All right, let's move on to emergency department per diem.
Okay, yes, so paragraph 11, this is emergency department per diem rates, 250,000 gross, 109,000 state. The allocation is primarily to our global commitment with a small portion to CHIP. And, as described, relatively brief description, just this is for folks who are awaiting placement for, inpatient psychiatric placement, but are in a hospital. This is to provide a per diem rate to the hospital for those services, but it needs to be reviewed and approved at DIVA. So, DIVA will have clinical oversight.
Okay.
Right. Item number 12, you've probably seen this in years past. This is the buy-in.
Oh, buy-in went up a lot, I'm sure.
It did, yes. If you saw, I think Stephanie sent me the CNN article over a weekend, and I had seen it on CNBC, but that big 14.5% increase to Medicare Part B premiums. And actually, I think there was an article, a news story just a day or two ago that the Health and Human Services Secretary wants CMS to take another look at this. So we'll keep our eyes open. But in the meantime, about 95% of this appropriation is for Part B, Medicare Part B, because most folks get Part A if they've worked. So that is most of what's driving this big increase. Is that increase to Medicare Part B. There's also some caseload. If we have more people on the rolls, there's going to be an increased cost. But it was that 14.5% increase. So again, spread across our global commitment budget. There's a slight decrease to state only. That's sort of a group of folks that don't fall cleanly into one category. So sort of as they're being classified, that number goes down a little bit. And then non-waiver is actually not CHIP in this case. It's a group called qualified individuals who don't qualify for Medicaid, but they are income eligible.
Yeah, the QIMBYs.
QIMBYs, yes, or QIs and QIMBYs, correct. So, well, this
and then
is
we
good.
have cuties.
This are Jeopardy, you'd be in the lead. So the next item, high-tech nursing payment reform, 152,000 gross and 67,000 state funds. And this is just a or it's a hybrid fee for service and fixed prospective payment model. But the main point is that this is to, for services that require high tech like dialysis machines, where you need to be a licensed practical nurse or a registered nurse as opposed to a home health aide to operate it. So providing funding for that initiative. Item number 14 is just another agency neutral transfer. Just $60,000 gross and 26 state. And this is from the Department of Children and Families. And specifically it's for individuals, children who are in foster care, receiving services from non-Vermont Medicaid providers. If DCF pays for it, it's actually under that investment cap, that global commitment investment cap, and it's constrained. but DIVA under our waiver can just provide these services as basic general commitment. And so DCF's transferring the funding to DIVA and DIVA's paying for it as basic global commitment. Number 15, so we talked about buy-in, that's Medicare Part A and mostly Part B. Clawback is Medicare Part D. And so when, the federal government lets states participate in this program and realize pharmacy savings, they wanted a lot of those savings back. And so this resides in our state-only category. There's actually a little bit of a decrease this year. And that's just because we're using that 6.2% enhanced FMAP funding on the front end to pay, which is reducing the state share. And so the amount that we have to pay back to the federal government is also slightly reduced. And so that's our clawback number, 171,000 reduction in our state-only appropriation. And then the last item is just a technical one. This is Children's Health Insurance Program, federal medical assistance percentage change. And this simply means that the federal in 22, the federal share of CHIP went up slightly. And so that means that for our allocable programs that are paid for with CHIP funds, the state share went down slightly. And so we're seeing a $281,000 reduction in our state share. And that is at the end of our presentation, if there are any questions.
I don't see any, other than what can one care do with their money once they get it. Otherwise, I think we're all set. And if we have any other questions, of course, we'll be following up. So, just to let you know, Medicaid's my section of the budget. So the person you'd probably be hearing from would be me or Stephanie on my behalf. So thank you for your presentation. I think the way you present it and walk us through is a good format with the explanations. And so thank you. With that, we're going to move on to, unless you want to stay, to the vet's home. I guess not, because you moved nursing homes over to Dale. So we finally let that happen. But thank you very much. And if we have any other questions, we'll get back to you. Thank you. And I'm assuming that we have the vet's home folks in the waiting room, Chrissy?
They are here with us now. Yes.
Oh, they are. All right.
Yep.
All right. Thank you very much for your time.
Thank you.
Okay. So Melissa's here.
Yes.
Do you have a document? Chrissy sent out a document. Do you want, I don't know if we need to pull anything up on the screen, or do you have slides that you want us to look at?
I can talk through it. I don't necessarily need to see the slides. I do not have the ability to turn my camera on, so I'm not ignoring everybody, but I am here.
All right. So, and you have other staff with you as well.
Yes, I want to introduce Asa Morin. In the past, I've brought Al Faxon with me. Al retired a little over a year ago, and Asa has been our COO now for several months, but she is not new to the Veterans Home. She was a social worker for us for 7 years, so she's been promoted from within. And Steve McClafferty is here as well. So with that, I'll get started if you'd like.
Thank you for the three of you being here today. So Melissa, are you doing the presentation? And
yes,
with backup from Asa and Stephen? Okay.
Yes. Yep. I want to start by giving a quick update as we're to where we are with COVID-19, and the numbers on the handout have changed significantly since the first of the year. These numbers were done before the holidays. We now have a total of 19 veteran or member cases, 66 staff cases, and we have lost a total of 4 veterans and members to COVID since its inception of March 2020. all of those individuals were offered hospitalization. They chose to remain here at the vet's home, seek minimally invasive treatment, and subsequently passed from COVID. And our average daily census is now 93. We have had 16 positive staff cases since January 2nd of this year, 6 just this morning. So we have had to put a hold on admissions. Our average daily census, as you can see, continues to decline as we continue to deal with this with COVID. The biggest impact is staffing, and I'm quite sure you've heard from other organizations about the staffing crisis in healthcare. 40% of VVH's staff is agency staff. And our rates for agency staff contracts continue to increase. We've had staff leave to go to work for the agencies because they're paying significantly more than we are. We are working with HR on a recruitment and retention program. As I told my staff, and I will continue to tell my staff who've worked through this and continue to work through this pandemic, VVH will not be offering sign-on bonuses. I've seen that game played all too well as I go and I get my bonus from facility A and then I move to facility B. So we are working with HR on some shift differentials and some retention bonuses, and to honor those that have worked here as well as to use as a recruitment tool. 84% of our staff is vaccinated, 78% of our LNAs and 75% of our nurses. 96% of our veterans are vaccinated. And
Melissa,
yeah.
I thought federal rules were such that if you got Medicaid dollars, your staff had to be vaccinated.
Yes and no. So you need to be vaccinated, or you have to have an approved medical or religious exemption. So the remaining 15% of our staff who are not vaccinated have exemptions either that have been approved or are under review at this point. Yep. We will be in compliance with the regulation. We will not risk losing any funding or receiving any fines. The newest deadlines are January 27th and February 26th. So we'll make sure that we are in compliance with those. We are focusing on getting our staff boosted.
Oh, Senator Sears?
Yeah, Melissa probably can't see me. So.
I can see you, yes.
Oh, you can see me, we can't see you. My question is the term agency staff. I want to make sure I'm clear what that means. Does that mean staff from traveling nurses or something like that? Or what does agency staff mean?
Agency staff is the same as travelers. Yes. They're the private
contract.
Yeah, contracted to staff. Yep.
And so some of your staff have become travelers?
Very few. We're very fortunate. I've heard from my colleagues that a lot of others have done that because the rate of pay is so high. Because there is no staff, as you know, you're quite sure you're all well aware. COVID really did perpetuate this perfect storm of healthcare staffing shortage that we saw coming. So.
How long is the contract for that? I heard from the Department of Children and Families and others that their contract runs out on, I believe it's March 31st. It might be February 28th, but it wasn't clear to me.
Yeah. So
is yours
unfortunately,
running out?
No, ours, we've had agency staff contracts on and off through the 11 years that I've been at the vet's home. We recently renewed ours. Ours are good for at least another 2 years. What we are seeing is frequent conversations about wanting to increase our daily rates with the contracted agencies because they have, the lion's share of the market. So.
Yep.
Okay, so getting into our budget adjustment request, we are asking for, my computer froze, hold on.
It looks like 2.3 million.
Yes, thank you. got it. So, and as you can see, the biggest bulk of that request, 1.5, is our agency staff. As I said, it's 40% is current of our staff's currently agency staffing. Other things that are impacting our staffing is as some of our temporary staff, which are VVH employees, if they work in other healthcare organizations, we may say to them, you have an outbreak where you're working, we don't want you to bring that here. Obviously, initially children not having school, we had to do some adjustments and with families to make sure that they could be home to help their children in school. And now we're seeing families testing positive and our staff needing to be home because they were a close contact or to care for a child who has COVID. So that continues to be an issue. And it's also, in addition to the agency staff, it's difficult to compete with incentives from our local hospital. SVMC is great. I received my care there, but they have some pretty substantial sign-on bonuses and retention bonuses that we just can't compete with. And if anybody's been to the supermarket lately, you know food costs have gone up, and you will see that we're requesting an additional $75,000 for that. One of the things that we're seeing is some of our categories, such as our meat, is up almost 8%. On average, we're seeing a 3% increase across all categories. And the other thing that we're having issues with is our suppliers may not have what we need. And we are sending our food service staff to our local Price Choppers and Shaw's and Hannaford with our credit card to purchase what we need. So that is an issue. Medical supplies is our next large increase at $175,000. We have been fortunate that working with the state, we now have a continual 6-month supply of PPE at the facility. That includes gowns, gloves, surgical masks, N95 masks, face shields, and goggles. And those costs have not decreased at all. They continue to go up, but we are set with our PPE. And our electricity and our ADS end user costs are true up to our actual expense. We've had to buy several new pieces of equipment, such as one is called an AccuShield device. At each of our entrances where our staff come in or our families come to visit, this machine automatically screens all of our visitors and staff for signs and symptoms of COVID and takes their temperature. Previous to purchasing these devices, we've had staff have to stand at the door and screen our visitors and our staff. We've purchased additional iPads and computers so our veterans and members can have continual visits with family members via FaceTime, Zoom, all of those technologies. And additionally, we've purchased some outdoor enclosures to provide family members some protection from the weather if they choose to visit outside vice in the building. And then the other big one is our safety repairs for maintenance. These were emergency repairs that had to take place. First one, we did fire caulking and smoke barrier sealing. Anytime we put a hole in a wall, we have to seal that. We found some areas that needed some additional fire caulking. That was $30,000. We had some leaks in our oxygen system, and those we needed to replace valves so that we weren't wasting oxygen. That cost $60,000. Floor repairs, 140,000 square feet of building dating back to the 60s. Floors get worn out, and those had to be fixed at $20,000 to make sure we didn't have any slip and fall issues. And under one of our wings, which is a wing, our waste piping is cast iron and is starting to fail. We had to spend $52,000 to get that repaired. That being said, we are now working with BGS on some new design plans for American Way. The VA offered to fund certain construction projects at 100% of the total cost. In the past, you've heard me talk about VA construction grants where it was the VA paid 65% of the project, the state paid the other 35%. We put in for some grant funding so we could address these waste pipe issues, as well as develop some more private rooms and additional visiting areas based on lessons learned from COVID. Going the wrong way. So that is basically the summary of our expenses. And we receive Medicare settlement money because we were paid at an interim rate of $445 per day. And then based on our cost report, we receive settlement funds that true us up to our actual costs. And you will see that we anticipate our estimated Vermont Medicaid settlement from FY20 to be $790,000. So we deducted that from those initial costs. So it's kind of where we are today.
Okay, so that gets us to the requested increase of after the settlement of 2.3.
Yes.
Other questions?
Yeah.
Yes,
Yes.
Senator Starr.
I was wondering, you gave us the daily census this year. What is that down from, Melissa?
We had been averaging pre-COVID of 125. So it's down significantly.
Yeah.
Yeah, down to 96.
Yes.
Yeah.
Today our census is,
actually.
yeah, our average census in December was 93.
Oh, 93.
Yep.
And only 4 passed on, so you haven't been able to take any new ones in.
We have done some admissions. We've had some deaths. I can get you those numbers for just people who passed out of the course of their illness, but we've had more than the 4 deaths, just 4 attributed to COVID. We went, not this year, last year, over almost 6 months, not admitting. We started early summer, or late spring, early summer, admitting 1 to 2 admissions a month. And we were continuing to do that. And now with this recent outbreak, we've had to stop all admissions to make sure that we have the staff to care for the residents we have in the building before we bring in any more veterans and members.
Okay. Senator Sears, your hand's up.
Yeah, it's a comment and an apology. When we first heard about the number of cases at the Veterans Home, I may have been a little over, but now comparing a little mistaken. And now comparing these numbers with what I hear from nursing homes and other facilities in the region, you're actually much better off than many. So you're doing something right, even though we all wish the numbers were 0.
Exactly. Thank you for that. I appreciate that, Senator. I've said repeatedly, first and foremost, it's been our staff. They have been so dedicated. They have rolled with every regulatory change, every change in PPE, making sure they're right on top of what we need to do. And, being 140,000 square feet, one level, gives us an internal flexibility to do isolation and have more private rooms where my colleagues don't. So we've been very fortunate with our setup and of course our staff.
Thank you. Any other questions? Thank you for your presentation and the slides. It gives us all the information I think we need to consider the request. I'm just looking at the screen. I don't see any. So with that, I guess, Melissa, thank you for you and your staff for being available this afternoon. And it's a nice segue to the next department, which is Aging and Independent Living, which has responsibility for nursing homes. So this is a good way of moving into that discussion. So thank you. And if we have any questions, obviously someone will be back in touch.
Thank you for your time. We appreciate it.
Yeah.
Take care.
Thank you.
So, Chrissy, do we have the folks from Dale?
We have Megan and Bill are in the room at the moment, and I believe we're just waiting on Commissioner White.
Okay. I'm sure Senator Sears, to pick up in your comment, I mean, the nursing homes, they've had to hire these contract nurses as well. Everything that the vets home has experienced, I think is, and you can see what it's going to do to occupancy rate, because rate setting is based, I think, on occupancy of like 90%. So some of the normal experiences really thrown out the window here with COVID.
Is there some way of controlling that so that, I mean,
mean
I
to-
know, well, I know a young person that went to work at UBM and only worked like a month or two and quit and went to work for traveling nurses and doubled their salary.
Right now, it's sort of like what the market will bear, and it's really a perverse where, I was talking to our local hospital and they said one nurse went to such an agency and was sent to Maine, and they had to get a contract nurse and who came from Maine. And he said it was like just dominoing positions around, and it's totally unregulated in terms of what the cost.
Well, one thing we could do is regulate the company that does hiring, that hires.
That's been discussed, but of course, a lot depends on if they're out of, I don't know, there might be some interstate issues here since some of these companies are actually serving multiple states.
Some of the people down at 204 Depot and at CL programs in Bennington are from Mississippi, Louisiana. I mean, they're from all over.
Yeah. Mm-hmm.
True traveling. I mean, they're not permanent.
No.
Those contracts are up, according to Commissioner Brown, are up on March 1st or 31st.
They do 3 months at a time, don't they?
I think so, Bobby. Yeah. But they've had such staffing shortages in nursing homes and other places. We'll hear about it, I'm sure, in a little bit.
Mm-hmm. Well, we know until basically the agency put more money in for contract nurses into nursing homes, that what we were seeing is a variation of the mental health problem, and that is people who don't require that level of care were still staying in the hospital and for prolonged periods because the nursing homes didn't have the staff to admit them. And so they were backed up in hospitals, and original round, I think they freed up 80 patients in various long-term care step-down facilities, but the plan was to actually add more. But it's awfully hard.
The whole system is in jeopardy. The entire social service system is in jeopardy. Some businesses are too, but
and it's not unique to Vermont, it's nationwide.
No, but I'm, from, it's in my own case, can't find aides to work.
Mm-hmm. I know.
So.
And it used to be, if it were unique to Vermont, then New Hampshire, Massachusetts, you could look to other states, but they're all in the same boat.
I'll be interested to hear what's going to happen to choices of care.
Well, has Monica come on now?
Yep, we have everybody here.
All right, so why don't we get started then? Thank you.
Chrissy, I'm wondering if you could send the summary for Dale, just because it won't open on the page.
It'd be my pleasure. I will resend it right now.
Thank you.
Okay. Since we have everyone here from Dale, I'm going to get started. You did send in your presentation, and which has been provided to us. I see you've got your usual narrative explanation as well as your financial, the summary sheet of your budgetary changes. So we can run through them either if you want to screen share, or we can, if we've got another device, we can refer to them there. What was the plan that you had to screen share?
I can certainly do that if that is the preference.
Okay. Committee, you want to screen share? Okay.
Sure.
I think everybody's saying that would be helpful rather than looking at another device. So yes, why don't we screen share, and then Commissioner White, are you doing the presentation?
Yes, I can. I will intend to start and tag in my team here if there are specific questions that fall within their respective areas of expertise. So for the record, I'm Monica White, Commissioner of the Department of Disabilities, Aging, and Independent Living. And this is my first time meeting some of you. So nice to meet you. I'll hope to meet you in the actual State House at some point along here. I'm joined today with Deputy Commissioner Megan Tierney Ward, and our Financial Director, Bill Kelly. So let me pull up the document here. Let's see. Is it going to let me share if I pull it up on the, it's not going to work. Hold on.
Monica, would you like me to share it for you?
That would be helpful because I'm trying to share it from where it's pulled up on, yes, that would be helpful.
Okay.
Great.
Thank you.
Thanks. Appreciate it.
I think we know the various divisions, so you don't need to spend a lot of time giving us some background. This committee is pretty experienced with the budget. And the newest member, I guess, well, it's Senator Ballant and Senator Baruth, but they're both quick studies.
Okay, great. And I'm always happy to do any one-on-one meet and greets, overviews of Dale overall, or any of our divisions or programs at any time, if that would be helpful.
Well, and we did, obviously, we've done this when we prepared the budget, the actual budget that's being adjusted here, so.
Okay, great. So Christy, if you wouldn't mind scrolling down to page 3.
Is that the money?
That's the money.
Okay.
We have a half an hour, so I'll attempt to be crisp. So our budget adjustments overall, our budget adjustment request is a total increase of 9.8 million, and that includes all funds, global commitment, general fund, and federal funds. However, the bulk of that are budget neutral across Dale's appropriations and AHS's appropriations, resulting in a total net increase of $150,000 of global commitment for our brain injury program. Everything else is net neutral across the agency. So pretty minimal impact overall. And I will walk through the points on the handout here and by appropriation. So starting with the Dale administration appropriation, The first would be to move expenditure authority from the Choices for Care. It's the Choices for Care reinvestment, which would be moving funds from our Choices for Care appropriation to our administration appropriation in the amount of 1.1, just over $1.1 million of general fund associated with an investigative system for our Adult Protective Services program, which is in alignment with Older Americans Act, Elder Justice Priority, as well as the Governor's priority of protecting vulnerable Vermonters. The next is also a net neutral move from our Choices for Care appropriation to our administrative appropriation for reinvestment funds for developing trainings for self-managed employers and employees. And then and that is $300,000 total. And then we are transferring, we're proposing to transfer $170,454 of general funds from neutral within VDA, within the Agency of Human Services, from VDH to Dale, as previous Secretary Smith had shared with House Appropriations last month. The intent of that budget neutral transfer would be to have the ability to jumpstart enhanced capacity for long-term care facility oversight during state fiscal year 22. Details of that will be for the state fiscal 23 budget will be available soon, and we'll look forward to further discussion on that after the governor's recommended budget is released next week. And so that would be a total of $1.5 million in our administration appropriation.
Let me ask,
Sure.
number one, the reinvestment. So we already have APS. What this is doing is enhancing the APS program, the system, to do more with home and community. In other words, I'm just trying to anticipate. Advocates are going to want people to be protected, but are they suggesting that this is taking money that was intended for services needed to support people in their homes and communities away from that to administrative services to support protection?
So a few things to that point. The statute in Title 33, Chapter 76 lists several specific circumstances in which Dale has the authority to, or has the ability to reinvest Choices for Care savings. And we, for this case, this cost for the investigative system does meet is an investment to serve older Vermonters and Vermonters with disabilities overall in the state. And so recognizing that it provides that the system we need to have an operable system that has enhanced capacity to support our adult protective services work. And we could not identify any other funding source to make it a reality to replace our current system, which is a vendor system run by WellSky, and really at significant risk of if that vendor chooses to unplug the existing system, then our entire adult protective services system, it would be at risk. So we've had several contract disputes with the existing vendor, and it would be a tremendous risk and really disastrous to Vermont vulnerable adults.
What does the contract, I'm sorry, the vendor that you have, what services are they providing under that contract?
So they run and operate the existing APS investigative system. And so we have a contract with WellSky for operating that system, which we use for all of our APS reports, intakes, and capturing information. And,
so it's an IT system. They're not actually providing investigative capacity, anything like that.
Right. All APS investigations are conducted by state of Vermont staff through our Division of Licensing and Protection.
All right. Is this a one-time expenditure?
Yes, a one-time expenditure.
Thank you.
I have
Sure.
a comment and a question.
Yes, Senator Sears.
I think that what you're driving at is, this is certainly against the spirit of Choices for Care. The idea behind Choices for Care was money saved in the system would be go back to the to provide care in the home for seniors and others. And
Or some of the savings could be used on the provider side to help shore up,
right,
you know, rates or reimbursement for services provided.
Yeah, things that was the spirit of Choices for Care. And when it passed, I believe it was the Douglas administration, and I was concerned then that we wouldn't keep that promise. And I'm even more concerned now when I see us taking money that is coming out of Choices for Care and going into what appears to be, I mean, I don't argue that we should be doing this, what you're proposing to do. The concern I have is taking it out of Choices for Care, particularly when we have such shortage of folks who are willing to work in the home with clients who need assistance. You know, and throughout the system. So.
All right. Well, we'll see. We'll see what feedback we get in terms of.
I would personally oppose this particular provision.
Okay. If I may, one thing that might be helpful is for the committee to see is we have a table that includes all of the Choices for Care reinvestments across. I think there are 5 total that provides additional detail. We'd be happy to send that along for review and consideration also.
What I'm concerned about is how those savings are being impacted by COVID when we know that nursing homes have not been able to accept a lot of patients, and the cost is being shifted over to the hospital side. So we're artificially inflating savings in the sense that we're not adjusting, I don't think, for those hospital prolonged stays. Although under the original Choices for Care, those hospital costs were supposed to be part of the calculation. Bill Kelly, you can maybe clarify this. You know, now that we've made Choices for Care part of the global commitment as opposed to a freestanding waiver, maybe that got changed. But I'm a little concerned about inflating savings that are and being interpreted as those are ongoing savings due to the lower utilization of nursing home beds because we're providing care in the community, when in reality, we're just providing care in a hospital setting. So that's part of also I need to understand better.
Okay, so the total amount available for reinvestment was about $6.1 million coming out of state fiscal year 21, which I believe was relatively in alignment with the amounts available out of previous fiscal years. But I would ask Bill if you can confirm and provide historical context on that front. That would be helpful.
Yeah, so there's a lot of, what's interesting is the savings from state fiscal year 21. I will agree, most of the savings were generated from the nursing home component, which is 2/3 of the Choices for Care budget. What's interesting is actuals through December of this year, the utilization in nursing home has increased, and the under budget through December this year is mostly in home and community based, but I digress a little bit. One thing with the statute, I just want to point out that in it's Title 33 in Section 76 that investments to serve older Vermonters with disabilities, it's allowed to be invested outside of Choice for Care per the statute. Understanding that non-Medicaid services are not eligible for federal match. So that is a component in the statute that was passed, I believe, last year.
Well, we'll take a look at it. I know that a couple of years, I don't know how long ago, we added language to allow savings to go to the provider side as well, recognizing that we had such a fragile system out there, that just to use it to expand services to more people and not try to provide or address the financial adequacy of reimbursement was also, we had to look at it in total. So we'll see what the House does. But I think you understand our concern of what's happening here.
And having said that, I want to just add that the overarching umbrella here is to keep it within home and community-based folks that are eligible for home and community-based services. So even with the APS, we're working under that umbrella.
All right, why don't we keep going? And we'll as a committee, we'll have more discussion as we get, into the final discussion around the budget adjustment.
Okay, great. So the next item is in our Dale Grants appropriation, and it is a transfer of funding within the Agency of Human Services to Dale of $568,000, year 3 of 3 for one-time funding for the support and services at home administrative costs as a global commitment MCO investment. The next couple of appropriations, DVVI grants, vocational rehabilitation grants, and developmental services. We are not requesting adjustments for any of those appropriations. The traumatic brain injury home and community-based waiver appropriation, this is the one area in which we are requesting an increase, and that is $150,000 gross global commitment, representing caseload pressure of 2 additional individuals over appropriation. And then in our Choices for Care appropriation, this is, and I might likely tag Bill Kelly in to help very articulately explain the moving parts here, but essentially includes $8.2 million of carry forward funds from 21 into 22, of which $2.1 million was obligated within the state fiscal 22 big bill. And what you see here as a $2.8 million down is the gross global commitment equivalent of the funds that were transferred into the administrative appropriation as general fund and as general fund and general fund and federal funds. So that represents the balance there through our Choices for Care appropriation. And I think that those are the highlights of all of the proposed changes within Dale's budget for budget adjustment.
I think I may need a little more clarity. Other members may need it as well. We just got from the Vets Home an request for a $2.3 million general fund budget adjustment that was driven by the very factors that are being experienced by our nursing home system throughout the state in terms of the need for contract nurses, the need for equipment, etc. And I know that there's language other places to do provider stabilization. And so I guess my question is there anything being proposed for other parts of Choices for Care, meaning nursing home level care? We're hearing from our residential care facilities in terms of their plight. We're hearing from the adult days. Can you tell me, is that being responded to separate and apart from the Dale budget adjustment, or are we not doing anything for those other parts of the Choices for Care delivery system?
So a good question. I will say that that is not addressed within Dale's budget adjustment request, and that the Agency of Human Services is working to address the myriad of funding pressures associated with all of the provider types that you mentioned and beyond centrally. So you've heard the BAA2, and we've yet to hear the governor's recommended budget for 13 has yet to be released, and I anticipate more detail will be available on the administration's proposals after that next week.
Okay. So we did, that's in the budget adjustment to the numbers that we have had presented earlier. You have heard obviously from all those providers that support Choices for Care services, I'm sure.
Yes.
Because obviously we're hearing from them as well. Other questions of the commissioner or Bill? Tracy, you're in the AHS central office?
Yes, Senator Kitchell.
Okay, so can you just help in light of this discussion, tell us what kind of proposal that you have in your budget adjustment to relative to the provider stabilization proposal that I believe the agency is advancing?
Yes, and I can actually share a document that has a talking points that has the list of the providers that we are focusing this relief on. But essentially, it's the $15 million general fund for that was carved out in the BAA 2.0. Would be for the non-HCBS providers, and then we have the HCBS providers funded out of the HCBS ARPA one-time FMAP bump spending plan.
Okay. So Stephanie, you've seen those, you'll help us make those connections. So for example, increases to adult days or increases to nursing homes are going to be part of that funding. They may be out of a different, I don't know, bucket, so to speak. Is that
Yes.
correct, Tracy?
Yeah, I would see it as provide. I think you coined the term provider stabilization. We're still working on the formula of how to get the money out the door, but yes, you know, it might not go towards rates, but it could go out in some other fashion.
Right. In terms of incentives or grants
Yes.
or
Workforce development, recruitment, retention. Correct.
okay. I think it'll be very helpful to see that. And then, of course, one might hope that the governor's budget would do some base increases to this provider community as well as mental health and others. You can't speak to that yet, but one might hope so. Okay.
Correct.
All right. So we can look at that proposal in greater detail in budget adjustment 2.
Correct.
And Stephanie, you've had a chance to look at that, those documents. I know Stephanie's multitasking. She's probably working with about 3 other committees. Other questions? We just need to put all these pieces together to understand it and how we're responding and what kind of relief is being proposed. Because obviously, what the administration is proposing for the vets home is not unique to the vets home. That's being experienced by other nursing home. And then we've got, our residential care facilities as well. So everybody's struggling with workforce and the cost of workforce. Stephanie, anything you want to add other than we'll chat about this?
No, I just heard you mention my name. I had to put a log on the fire.
Oh, well, I can understand that. My son came in to throw some more coal on the furnace. So it's fortunate to have somebody extra around. We're just talking about the state of our whole provider community, our nursing homes and their workforce and their expenditures versus residential care facilities, adult days, and then the difficulty of finding probably personal care providers for people who are in choices for care in their homes. So it's just permeating everything. Questions of the committee other than just trying to stay warm on a very cold winter day? Okay, so what we have is the original Dale proposal, and then the other funding or the additional requests will directly relate to addressing those pressure points of the provider, of the other parts of the provider community. Okay, thank you. Committee, do I speak up if I'm not seeing you? Because I don't have Senator Westman and Senator Starr. Megan, do you have anything you want to add? Or Senator Westman?
Yeah, Commissioner White, I will be in touch, and I will be asking for caseload numbers for whatever we have for nursing homes, adult day, and where all of those are.
Okay.
Absolutely, Senator Westman. Thank you.
Was there anything else I was supposed to ask that I've forgotten?
Senator Kitchell, you asked briefly if there was anything to add, and I just wanted to say that I sent an email with the attached complete list of reinvestments for choices for care. So you'll have a copy of that.
All right, thank you.
I would ask in that vein to answer Senator Sears's question. Have we ever in choices for care taken monies out that when we talk about reinvestment and put it into systems? In the past?
Yep, we can look into that.
Yes, if you could, that would be helpful.
I can assure the committee that we have reinvested funds outside of choices for care, even prior to the current statute.
It would be helpful to have that.
Okay. I guess what we're asking is just setting a precedent that, and if so, it's nice to know it, but perhaps it's already been set. Other questions or information people would find helpful? Obviously, once we get into the big bill, we'll be getting more detailed information about your proposal for 23 budget.
I'd be
Yes,
interested.
Alice.
I'd be interested in knowing numbers with regard to number of cases with adult protective services during COVID, whether they were down or up, or were they all investigated, or what happened? If you could get that, please.
Sure.
Okay. Any other requests? If not, it's 3:03, so we're just about on time. And I think then, Chrissy, this is the end of our scheduled testimony, right, today?
That's correct. Yes.
Okay. So committee, I'm going to go offline now that we've finished the testimony for day, and let the folks from Dale and the agency get back to their other work. And